I think we'll move to the next session, and this is novel treatment targets and approaches. You wouldn't believe. Can you move the top part, if possible?
There is two questions.
Good, let's go. Two questions, yeah. Okay, so the question says here, sometimes 4 times oral antihistamines cause gastritis. Patient never had before, developed only after Telfast 4 times. What is your comments on this? Our expert panel, what do you think?
With Telfast 1, so 4 times ago, gastritis was really very risky because it seemed to be rapidly good on the stomach, but after food was not. That's one small observation. Only thing is, that's what we saw in the people. So if you are gastritis, then of course you should cut down and do the practice and medication of selecting and oxidation. So the next one is
Mohamed, do you have any views? 4-4.
So, for example, if it's not like it's 10 grams for adult, for the pediatric it's 500 grams, they can go up to 10 grams.
Excellent. So anyway, so back to the questions, just to summarize. So yes, you can, but in my experience, even given 4 folds, it doesn't really cause gastritis. I mean, I haven't seen it. But if that happens, then the expert panel's view here is to reduce the dose and look for other maybe causes, or add PPI or something like this, or add ranitidine, which is H2 antagonist. Again, there is evidence that there is no need to add H2 antagonist in patients with urticaria. But if gastritis happens, then I think we need to reduce the dose. And if it's linked, if you think it's linked, or the patient thinks that it's linked, then we might reduce the dose or change.
One thing from Abuzakouk, you may have seen this as well. I see strangely H2 blocker and molecules are standard for all CSU patients, but general practitioners. So I guess we need to educate them.
Of course, there is no rule. There is no rule for H2 and montuleucast. There's no rule. There's no evidence that they work. And actually, the guidelines say do not use them because there is no rule for montuleucast and for H2 antagonist.
It's like that, one thing regarding the pattern, like Zodiac can give the formation with in hospital from the H6, when it comes to one of the planning, this one license from the but since it has something to do with the task to get that population, we don't have that all but it's going to be school because this year there was a distance for the
Right. So again, like Dr. Mohamed said, yes, you can use the same 4-fold, but pediatric doses. So, and you can use Xolair for patients above 12. Excellent. So that's good. We're moving on. Can we just take this? Okay. So you wouldn't believe what's behind the scenes. There is a lot of biologics actually are being sort of looked at in chronic spontaneous urticaria. You wouldn't believe this. So this is a busy slide. I'm not going to go into details of this, but if you look at panel A, so we have this panel A here, and this is panel B. So these are the new biologics. There are 2 different types of biologics. Those who act on the cellular targets and those who act on the soluble targets. And there are a number of them acting on the cell markers here, for example, like this monoclonal antibody with lots of numbers and 2 letters here that act on the CD200R receptor on mast cells. There is the CDX0159 monoclonal antibody that actually inhibits the c-KIT receptor there. There is this monoclonal antibody that works on the as another cell marker there, or cell receptor. There is a lot of stuff going on there, and these are actual studies going on at the moment. Now, for the soluble mediators, there are ligelizumab, and which is I'm going to talk about in a few minutes, and there is the anti-TSLP monoclonal antibody, which is actually coming along as well to treat patients with chronic urticaria. And there is also the Dupixent, which again you're mostly familiar with, that actually acts on the IL-4 receptor. So there is a lot of stuff going on there, and of course these are off-label. This part, like the Dupixent for the moment, and the mepolizumab and the anti-IL-5s, they're all off-label biologics for chronic spontaneous urticaria. And where's this guy? So I need your help here. Sorry. The slides are not moving. So as I said, there's a lot behind the scenes there. When I was doing the review for this masterclass, I really was shocked to see this amount of biologics that are currently being under investigation to treat CSU. Okay, so and again, this is just to summarize what we have. So we have the off-label biologics. So we have the omalizumab, which is you're familiar with, and this is FDA approved since 2014 and proven efficacious and safe in chronic urticaria. And you have the off-label biologics, Dupi, Binra, and Skibitam, which binds to the IL-17, and then you have the novel biologic under development, which is this list here. Now, this is the timeline. So we're expecting to have Dupi and ligelizumab being FDA approved soon, hopefully in 2023, and look at the plethora of biologics that are in development, for urticaria. And something that has been mentioned by Dr. Rabi, I think, is the topical stuff. So there are, a lot of topical preparations that actually are currently being developed to treat patients with chronic spontaneous urticaria. Now, I'm not going to spend a lot of time here, but as you know, this is just to remind you that dupilumab or Dupixent binds to the IL-4 receptor alpha, which is present on the IL-4 receptor as well as IL-13. So it actually binds the IL-4 receptor on both receptors, IL-13 and IL-4, and it inhibits, the stimulation of the JAKs in the cytoplasm. And once you block the IL-4, IL-13, then you have, the reduction of mediators produced by all of these cells. So you have less itch, you have less IgE production, and so on and so forth. Ligelizumab has been is really the flavor of the month, if you like, and it's been this is a landmark publication by Mark Smorer in New England Journal of Medicine. So this monoclonal antibody basically is a humanized monoclonal antibody that binds to the high affinity IgE receptor on the mast cell compared to omalizumab. So ligelizumab inhibition is really very, very high, and compared to omalizumab. And this is really the landmark study that was published by Mark Smorer and group. And what they've looked at about around 400 patients with refractory CSU, and they found that 42% of on ligelizumab were symptom-free at week 12 versus 26 on omalizumab. So this is really a huge difference. They found that ligelizumab works faster as early as 4 weeks after initiation of treatment. But I mean, we found that even patients with omalizumab actually can respond from the first 1 or 2 doses, as I'll show you in my next presentation. And they found in this study that complete symptom control depends. There was no huge difference between the doses that they've used. They've used 72 milligrams and 240 milligrams in these patients, and they found that actually symptom control is far better than patients on omalizumab or placebo. The other interesting bit from this study is that time to relapse after treatment discontinuations was markedly longer with the ligelizumab group. So I think this is something we'll always be interested in, and we're looking forward to use ligelizumab in the future. The thing is now Novartis is competing against itself. So ligelizumab versus omalizumab. I'm not sure what's going to happen to omalizumab. So this is another talk that we need to do with Novartis. Okay, questions or?